Number one is I want to thank you all for coming. It's really terrific. Most of you know we arranged the Giant game in London, so that wouldn't be a disturbance. Some of the crazy people, if you're still for the Jets, we lost them tonight, but it's great having you. We also have a turnout from all over a lot of the world. People and friends and family came in from California, Florida, St. Louis, Anguilla, hey, Upper East Side, yeah, with the traffic, and even far away Brooklyn. Montreal. Canada, is that Montreal? Yeah. It's really a pleasure to have you all, and this is great turnout, and the people who couldn't be here, we met, more than met, Columbia's tough goals for me, so I'm really, really very pleased. I know I sort of got you here. First of all, I hope you're all recovering with your arm problems. I know I twisted a lot of arms, so I am really very sorry. Also, I sort of got you here under false pretenses. When we said in the invite, there's going to be a gray-haired, old guy from Brooklyn. No, it's not Bernie Sanders, it's me. I'm sorry, but there's other terrific news. I am not making a speech tonight. That wasn't funny. You've heard enough speeches from me, and I think the speakers that you will hear from tonight are really very special and people that really know a lot about, obviously, a very serious topic. And what I wanted to really spend a little time on first is that this crowd reminds me of my bar mitzvah. And any of you who are biblical scholars will know when you're 83, that is the time you can have a second bar mitzvah. So you can check it on Google, and it's so, and I'm 83. So it's wonderful. The good news, no candle lighting ceremony. Before you get rid of me, I only wanted to do a few shout-outs especially. Number one, you all know the story of why we're here tonight. But how did we actually get here? How did it work out? Number one is, luckily I have a good friend and tennis buddy who was ex-chief of staff of Columbia Presbyterian. And I talked with him one day. I said, I think I saw something about Columbia starting something and this. And he made sure to check on it. And he introduced me to the head of the whole psychiatric division, Dr. Jeffrey Lieberman. And so that's how we started. And Alan, I'd like to have you just stand up or wave for a minute. Please stand up. We wouldn't be here tonight without him. He didn't know anything. So when I was there and I talked with Dr. Lieberman, he said, okay, I think we are starting. Maybe we can do something. So he said the gentleman from Israel that they have, who's running the program, is Professor Yuval Neria. And I said, why don't you talk with him? So I traipsed down and we talked for a while. And he turned out to be a really wonderful guy that I'm very fond of. And I've met his wife too, I'm fond of her. And he, after listening to me and hearing the story, said, okay, let's go for it. Even though they were used to dealing with corporations and more big shots than me. So we said, okay, looks like that could happen. Now how do we make it happen? Which was the implementation and anything of it. Columbia has a terrific, by the way, this is Dr. Nuria, you're going to hear from him later. And Columbia has a terrific development team. They are the ones to make sure all these things can happen. And the first lady I met head of it her name was Regina Ropa, and we had some conversations and finally agreed to what our goals were and how we could make it happen, which was a year ago. And then I started sending emails to her, and around 5 a.m. when the emails came in, her husband said, there must be some crisis. You keep getting these 5 a.m. emails. Well, she was very smart. She, 2 weeks later, got someone else to join her. But Regina, where are you?
I'm back here. Very true.
And then who joined her was Shannon Harknett, who had the inestimable pleasure of working with me the past 3 or 4 months, and you've all seen her name call Shannon, send Shannon. Without her, she does really exist. She was fabulous. Whatever I wanted, email, phone calls, meetings, she was stepped up to the plate. So I only want to tell you, without Shannon, we wouldn't be here tonight. Shannon, where are you?
We're here.
If you want something done, by the way, they are a dynamic duo, I must tell you. And, of course, the person who's responsible for everything. She made sure Teddy, in his latter part of his life, was taken care of. She made sure I was taken care of the last 60 years. And I don't think there's anyone else on earth that could be taking care of me. I mean, most of my friends know I am what they call, shall we say, high maintenance. Maybe I don't think so, but maybe perhaps it is. But Glenna and I talked about, in our last life, we were married. And I was so bad, if you can hard to believe, that she came back to try and straighten me out. And she just informed me last week, enough is enough. She is not coming back a third time. So if anyone else here wants to volunteer, talk to me later. So enough from me. It's the program, I think, is going to be a terrific one. And our moderator today is someone who I met just recently. Even though he's a Yaley, he's still okay. Dr. Bruce Shapiro is the director of the DART Trauma Center and Journalism, and I think you're going to find him quite interesting. So thank you again all for coming. It's a pleasure, and it's particularly wonderful to have my grandchildren here.
Hi, I am Bruce Shapiro. I am neither a doctor nor a Yaley. I teach there once in a while, but my day job, where I hang my hat, is at the Columbia University Graduate School of Journalism, where I direct a project called the DART Center for Journalism and Trauma, which brings together clinicians, researchers, and people in my profession, journalism, to think about violence and aftermath and how we tell the stories of some of the most difficult experiences that people can go through. We are not here tonight to talk about journalism, though. We are here to talk about veterans. There are few issues more pertinent and alive to probably all of you in this room, whether it's as veterans yourselves, and I'm sure there are some here, or as family members, friends, loved ones, or simply as citizens. We are going to have a conversation tonight about the cutting edge of trauma science. We are blessed to live in an era where researchers and clinicians have dug deep down into the roots of psychological injury. Issues that used to be ignored or stigmatized or taken for granted now are at the front of the research agenda, and in particular at the Columbia University School of Medicine's Department of Psychiatry, where my friend Yuval Neria runs the PTSD Trauma and Research Program. We're going to have a conversation tonight with Dr. Neria and a couple of his colleagues about the promise, the successes, and also some of the challenges facing the treatment of veterans, the understanding of psychological injury like PTSD. We'll take a deep dive into that, and that's all because we were brought together here by our mutual friend, Marty. I know that in the letter to you, inviting you here, Marty mentioned a little bit about his motivation for bringing us together. But in speaking with him a couple weeks ago, it was very clear to me that there was more to it. There's a story here, which is the source of a passion and a cause that he's undertaken. And rather than have him try to tell what is a fairly personal story in front of a microphone, Marty agreed to sit down with me in front of a camera a couple weeks ago and be interviewed. We talked for about an hour. My colleague Ariel Richin, who's back there videotaping this event, taped it up at Columbia, and we're going to show just a few minutes of that conversation because I think it frames very well why we are here. Again, whether it is as veterans ourselves, family members like Marty and Glenna, or as citizens. So we'll show that. Then I'm going to turn it over to Yuval and his colleagues, and I'll come back and moderate it from there. But let's start with some tape.
Teddy was born in 25, me in 33. And he always, even when I guess after being a toddler, I always looked up to him because I was very lucky. He was a fabulous brother, very smart, athlete. He was also the first grandchild. Therefore, all of that goes with it. He was the golden boy. I knew all his friends. I still remember their names. And it took me to see Frank Sinatra and everything. So I didn't understand how lucky I was, because a lot of older brothers were not like that. But then the scene changes. He decided to volunteer for the Army. As the war came, I think it was 42 or 43. And then when he came home, things started to happen in the house. And I don't think I'd like to describe it in detail, other than there were some really horrible things. He was imagining, probably still fighting, and no one said what was happening. I mean, the 50s were a time where you said nothing. So what was horrible is that to see this, and no one discussed it with me, my folks, because I'm sure I understand it more now I'm older, but it was crazy that they didn't sit down and say, look, this is what's happened. It's not his fault. He was in the Army, and we didn't even know what happened. So that was, I knew he had the Bronze Star, but we didn't know what, and he didn't want to talk about it. So my mother had a really tough time, and that eventually he went for help, but he had to go into then the veterans home. So he was there most of the time. Actually, most of my friends never even knew I had a brother. Those who knew my brother wondered. So I said, he went to California or something. So there was no one you could talk about with it. Even when I was about to, and Glenna was from Massachusetts, it was almost before we weren't dating that long when we got married, but even with her, I didn't tell her till a couple of weeks before we got engaged.
Really? You didn't tell her that you had a brother?
It was a non-topic. But he was very lucky she came along. He loved her because she was really the caretaker. While I was traveling on over, whatever, I never had to worry, was he taken care of? And that, she encouraged me. She knew it was very painful for me. I think in those days, people had a tough time, particularly of dealing with anything that wasn't good. I mean, the worst part, which took me a while to process until we had the responsibility, is that he did something wonderful. One of his buddies called me. We were in Massachusetts. Funny, he was the Massachusetts Internal Revenue. What the hell you want with me? So he said, I've been looking for your brother, and I found out, he probably did like you, look for the records. He found him, and that we were his, guardians. He says, I want to tell you why I'm looking for him. Your brother saved my life and 5 others, but unfortunately one of his best friends was killed in the thing next to him. Well, what it did is it explained everything. As a kid of 19 he was at that time, what the hell, could I have handled something like that? So I think I'm more sympathetic to my folks now because they had to deal with it. So maybe we'll stop for a minute. After he died, I would say a lot of times I used to think about it, and driving along I started crying because I started to think, God, what kind of life that he had. Can you imagine? He was living a tortured life for 65 years. And, no one could really help him. And what kind of life was that? And then what I remembered of him, that's why it's so painful, of Mr. Wonderful, until he went on the Army. So that's why I would say when people are talking about wars, and they have no idea what this can cause. They don't even count it on the injury list.
What made you decide to move in a public direction with this?
But once his buddy called, I would say that's a defining moment of me starting to feel, well, you know, he did this wonderful thing. And by doing this, something will live on in Teddy's memory. I feel, you know what? It's something that he would have loved.
Thank you, everybody, for attending tonight. Marty and Glenna, the kids, you know, the entire family, the friends from Brooklyn and the friends from Massachusetts, and my team, my family. And thank you, everybody, my colleagues, my esteemed colleagues that you will hear later. Thank you very much for coming. And a special thanks to Bruce for not only being an integral part of tonight's program, but also producing this very moving and a little bit painful video. I am Dr. Yuval Neria, Director of PTSD and Trauma at the Department of Psychiatry and the New York State Psychiatric Institute. I am a veteran myself, and from the Israeli army, came to New York after the attacks of 9/11, and devoted my career to the understanding of the causes of PTSD and the treatment of PTSD. A couple of words about Marty. He already told the story, but just to give you more perspective, I met him, you know, late last year, and I was very impressed by the desire to help people of PTSD. And initially, I didn't know the personal story, but once I learned from him about Teddy, about his brave service to this country, in Europe of 1944, 1945. I understood how important it may be if Marty can close this circle and have the opportunity to connect to my team, and to Colombia at large in order to develop this fantastic project at Columbia. The story of Teddy is pretty unique, but unfortunately, it's not very uncommon. In fact, many veterans who are coming back from Iraq and Afghanistan these days may tell very similar stories to their families, to their spouses, to their kids. The PTSD as a disorder is very common among veterans, but not only. PTSD is very common, period. It's very common among civilians, among kids, among women who are assaulted or attacked, or people who are going through disasters and terrorist events, car accidents. PTSD is very common. So I'm very grateful for Marty. I know my team is, to Glenna's, to the kids, to the generosity, to the unbelievable effort to put this together. I'm sure many of you got numerous phone calls, and as we got from Marty, making sure that everything is done here in order to make this successful. Let's go to the PTSD slide. So, quick facts about PTSD. As you can see, PTSD is very debilitating and resulted from severe exposure. I already spoke about it. A little bit about the symptoms. PTSD symptoms are painful, and anxiety-provoking. They may include sleep problems, repetitive images and memories who are coming to mind, and frequently entails painful memories, avoidance of trauma reminders, and pretty much a lot of guilt. And I think you had a little bit of sense of guilt this evening. My program is very committed to study PTSD, to understand the treatment of PTSD. In January this year, we launched the first ever Veterans Clinic at Columbia, which is a very interesting experiment, I would say. Columbia is not affiliated with the VA, as many of you know, and there was a reluctance really to engage veteran populations in our institute, and we were grateful to a number of donors and great colleagues and administrators in our department really to put this together for veterans who avoid or tend to avoid VA service, unfortunately. Veterans can be quite bitter about what they see and feel in the VA centers across this nation, not everywhere, but at many places. And when they can seek treatment and assessment and referrals in our center, they find a different atmosphere. They find people who welcome them and give them really the feelings that they can be at home. Some of my teams are veterans themselves, so we are very sensitive to the veterans populations. But moreover, we also accept children and wives for treatment. Wives and children are not eligible to VA service care, to VA care, unfortunately. And we see them and we provide them treatment for no cost, which is very important. My program has a variety of ongoing research initiatives. We're going to talk about it with my colleagues later, ranging from brain imaging of patients with PTSD before and after treatment, going all the way to equine-assisted therapy, psychotherapy research, and medication research. We greatly rely on the quality of our team members, and that's true for my lab, but also for any other lab in every place in this country. It's human beings that conduct research and provide treatment. And we rely on them, we rely on their moral standards and integrity and expertise. And we want to be competitive, really, to recruit the best people. So we are very lucky to have great young people coming to us, and we would like to make it happen also for the future. And without further ado, and in order to learn how research at Columbia is essential to the treatment of patients with PTSD, I would like to introduce my colleagues here, Dr. Scott Small, a colleague and a friend of mine, and Dr. Blair Simpson. Both of them are great scientists and clinicians, and I'm very fortunate to have them coming tonight to discuss what can be done for veterans and civilians with PTSD. Thank you.
We will now hear briefly from Blair Simpson, Professor Blair Simpson. I'll introduce you in one sec. Again from Yuval, and then from Scott Small, each of whom will give us brief brushstrokes of their current research and its application, and then we'll have some time for conversation after that. So I'm going to start by introducing Blair Simpson, who has more letters after her name than any human being should have. MD, PhD, professor of psychiatry, and director of the Anxiety Disorders Clinic and Center of Obsessive Compulsive and Related Disorders. She's going to talk a little bit, as you can see there, on using neuroscience to transform treatments for PTSD.
Thank you, Bruce. And thank you, Yuval, for inviting me and for all of you to be here. And I feel very honored to be at really what's an event which seems to me is the love and dedication of a brother, which is very beautiful after all these years. Yuval and I work very closely together. I direct the Anxiety Disorders Clinic, and what he asked me to do was to provide a brief overview to set PTSD in context. So for anyone in this room who doesn't know that much about PTSD or doesn't even know that much about anxiety, I'm hoping in the next 5 minutes to sort of quickly explain how this sits. Now, all of us know what anxiety is, right? When I was late tonight because of the subway, I felt a little anxious about whether I was going to make it to my panel on time. And all of us who, if you've ever been in the face of an immediate danger, you have that sort of fear reaction, right? We've all had that. Those are normal experiences of everyday life. But the sorts of patients that Yuval and I work with, they don't have normal anxiety. They have anxiety and fear that is really disabling and derails their life. But our message tonight is actually one of hope. And the message is of how neuroscience is starting to transform what we know about anxiety and then giving us new avenues for treatments. So let me just start with, again, this is big overview. Well, so what are anxiety disorders? And they're a group of disorders, as I said, characterized by fear and anxiety. And some of them, like specific, and you may have, there are just some of them are listed here on this slide, and you may have recognized some of their names. Some of them, like specific phobia, are very, very focal fears, like a fear of heights, right? Or a fear of bugs, or a fear of dogs. Whereas others, like generalized anxiety disorder, are much more sort of general, diffuse, free-floating anxiety. These are the worrywarts in our life who can never stop worrying. But most of the rest have some combination of both specific fears and that general anxiety. Just what differs between them is what triggers that anxiety or fear. And in addition, all the disorders also have different symptoms, which is why we call them different things. And my particular expertise is in obsessive compulsive disorder. Yuval's is in PTSD, and that's the focus of tonight. So next slide. So this is what often surprises people, is that when the World Health Organization makes lists of the world's most disabling illnesses, and I don't mean mental health illnesses, I mean all illnesses, diabetes, high blood pressure, heart disease, everything, cancer. What's surprising to people is, and again, depending on the list, depending on the year, anxiety disorders moves from somewhere 6th to 9th. Well, the most recent study is it's 9th out of the top 30 in the world of most disabling. And I think there are really two reasons for that. One is how common they are. So anxiety disorders in America, about 1/3 of Americans will have an anxiety disorder in their lifetime, which means it's likely that statistically that there are many people in this room who have an anxiety disorder, and for sure, all of you know people with anxiety disorders, even if you don't know it. The other thing is that often anxiety disorders start in childhood or adolescence, which means that if you get an anxiety disorder young, like Marty's brother, and it isn't treated, you can have it the rest of your life. And so you add that up, these disorders can be quite disabling. Here's the good news, which is over the last 10 or 15 years, there's just been an explosion of research about the brain circuits that underlie anxiety. And on the left-hand side, I'm showing you a sort of schematic from a rodent brain cut from the side. And by now, we know all those different brain areas that are responsible for producing different aspects of that anxiety, those anxiety symptoms, which rodents have too, or that fear reaction. And we not only know how all those different brain areas are connected to each other, within the brain areas, we actually even know specific synapses that are critically important for different aspects of that fear response. But what's really interesting, I think, is we've moved beyond just these rodent studies, and some of the same paradigms that you can study in these rodents, you can actually study in healthy humans, and then actually in people with anxiety disorders. And Yuval and his group have done some of this work. And what you see is that we have many of the same anxiety systems as these rodents do. Now, why does that matter? The reason why that matters is you can now ask questions like, well, do people with PTSD, for example, have abnormalities in these brain circuitries that underlie fear and anxiety symptoms? And again, Yuval's group has done some of that work, and the answer is yes. And the second question you can ask is, well, can you enhance the functioning of those brain circuits and then improve treatment outcomes? And the answer to that one is also yes, and Yuval's group has done some of that work. So that type of approach, going from animal research to human research and back again to try to open up how we understand PTSD and try to open up new treatments. I'm illustrating on the next slide, and what we call this is patient-oriented translational research. And what I'm showing you is it's not just from the bench to the bedside. It actually is a much more iterative process where basic findings in animals can drive studies in healthy humans, and those studies in healthy humans can then drive studies in patients. And all of that is, again, opening up new understandings about what causes the symptoms, and then that opens up new thought about how to treat the symptoms. And that's what you're going to hear more about from both Yuval and from Scott.
Thank you, Blair. And we'll come back to Blair and to everyone else with questions. Yuval, why don't you take us now where we need to go? And while he walks up there, I will officially tell you Yuval's title, Professor of Medical Psychology in the Departments of Psychiatry and Epidemiology, and the Director of the PTSD Trauma and Research and Treatment Program.
So just to put, Blair, a little speech in context, what I think unites us, both Blair, Scott, and myself, is that we are serious about understanding the brain of our patients, but not so much only for theoretical perspective, although we are very interested in that, but we are really seeking to understand which, brain areas are really meaningful to the various disorders, whether it's OCD, PTSD. In Scott's case, you will hear later, it's about Alzheimer and schizophrenia, etc. And whether this knowledge can really serve us with regard to finding the best treatment for these patients. There is a long way to go, but we have started, in a number of meaningful steps. And the most important thing that we are trying to do is to transform the way clinicians really understand the diagnosis of the patients and how they treat them. So for more than a century, really, the way psychiatrists and psychologists treat their patients is by asking them how do they feel and what do they remember from their childhood, and kind of go from there. With all sorts of very interesting hypotheses about the cause of the suffering and whether they suffered in childhood in a way that really impacted their life moving forward. Since the last 20 years or so, perhaps a little bit more, there is really a revolution in our ability to do two things. First of all, to start objectively diagnose our patients in a more objective ways, not so much based on what they tell us in a very subjective way, but also trying to see whether we can also measure our success in treatment in a more objective way. So I kind of, summarized a little bit of what's going on in my lab only in the last year. This is 2016, and a number of stuff that we kind of published in professional journals, just to give you a hint of the difference that we hope to make in the area of PTSD. So, as Blair suggested, our brain is very much involved in anxiety and fear. And anxiety and fear are very much related to the way a veteran deals with horrible experiences in combat, or a car accident survivor is dealing with the memory of the car accident. And basically, there are a number of areas in the brain that are trying to target the cause of fear in the brain and to modulate it, to make it less, disturbing. We are talking, for example, about the hippocampus, which is really kind of an area that also Scott is very interested to understand. So a number of findings about the hippocampus. It's a very small area that very much involved in memory. PTSD is not only about fear, it's only about memory, right? Soldiers, invest a lot of time in memorizing what happened to them. Many of them cannot really recall everything, but they recall the trauma very, very well. And basically, contrary to what was hypothesized many, many years ago by psychoanalysts, traumas are quite easily to recall and to memorize. And our patients really appreciate an opportunity to talk about their traumas. So what we found, for example, that the structure of the hippocampus, if the hippocampus is too small, the risk for PTSD is getting higher. So the smaller the hippocampus, the higher the risk to develop PTSD. This was demonstrated by a number of groups before us, but we kind of, found it as well in our studies. But not only that, we found that the size of the hippocampus, this very little thing, has a lot to do with whether a patient will succeed in treatment or not. In other ways, whether a patient can recover from PTSD over time. Now, we found that psychotherapy is not doing great with smaller hippocampus, but perhaps medication will do better. And here you go. You have perhaps a way to understand people who don't respond to psychotherapy and to refer them to other sorts of therapies. And we have some medications that are pretty useful. We are doing all sorts of stuff in order to help people who are not really helped by psychotherapy. We also found that recovery from PTSD at Columbia, when a patient is coming to receive treatment, this is an NIMH-funded study, remission or recovery from PTSD is associated with structural changes in the brain that are measurable. And we also understood that the brain has some areas of the brain that their size and how thick, those areas in the brain, the cortical areas of the brain are very much related to how much we need this certain area to work in the brain. So if there is less need for this area to work as hard as before, this area can kind of, go into a process of pruning in order to shed a little bit of size and a little bit of thickness of this area, which is very, very interesting. So the brain is very plastic. The brain tend to change over time. We are, as we go in life, as we go through traumas, and if we go to treatment, and we can follow up, those areas in the brain, which is very, very important. Changes in the brain following treatment can provide us evidence about either a success or about a failure, really, to treat a patient. And that's exactly what we are looking to find. And finally, what we really would like to do is to advance treatments. And that's kind of the little bit of the pessimistic side of me. PTSD treatment is a little bit stuck, I would say, in the last 10, 15 years, especially on the medication front. Those big promise medications like Prozac tends to work pretty well, but not always. In fact, about 50% of the patients with PTSD are not really helped by what we can offer them today. And there need to be a greater push and a more successful push in order to advance our understanding of the brain and the way we treat people. So we want to do that. And we also are very interested to to expand our clinic for veterans. Right now we are still working in a more experimental way. We test whether our model are really working. We would like to bring more clinicians and more researchers in order to expand our team to recruit the best clinicians and scientists to the PTSD research group. And by that, I will finish my little speech. I would like to ask Dr. Scott Small to come to the podium, and thank you very much.
Good evening. Thank you for arranging this, Marty, and actually thank you for the video. I was really moved. I just met you as I was walking in, but it was incredibly moving, and to hear about Teddy. And yes, I can. And one of I just want to start a little bit before. I wasn't formally introduced, but that's okay. In fact, I am, as you can see, the director of the Alzheimer's Disease Research Center at Columbia. And so I might be the odd person out here. My primary appointment is neurology, not psychiatry. There's a lot of reasons for me to be here tonight. We are working on PTSD with Yuval. PTSD is an epidemic, although the epidemic probably is not just in the current wars. It's been throughout many wars. It's only now been diagnosed, and it's perhaps the disorder that needs the most help in terms of diagnosis, treatment, and understanding. But there's another reason, and that's more personal. I'm not sure if that is clear to everyone, and that's Yuval himself. So I will spend one of my dedicated 3 minutes talking about Yuval. So I first heard about Yuval as a teenager. I actually grew up in Israel, despite my Hebraic name. And Yuval is, Israel is a country with many wars, many heroes. Yuval is the single most decorated soldier of all of Israelis' wars. In the bloodiest war, the Yom Kippur War, the 1973 war, in the bloodiest battle on the southern front in the Sinai Peninsula. And he has a remarkable book, which I don't think it is yet translated into English, but it should be. And the wonderful thing about Yuval is he has that unique experience, but as you just saw or interacted with him earlier or spoken to him before, he's a true scholar. So he's this rare soldier and scholar, and I think he's creating one of the leading PTSD centers in the world. And so I am delighted to be here because of PTSD, but also because Yuval and I have become fast friends in this collective effort and in a slightly collective background, because I grew up in Israel and also served in the military there. My focus, as you've already said, is on the structure of the brain called the hippocampus. Before I talk about that, let me put this in broader context. One approach, one key for trying to understand, diagnose, maybe treat any disorder of the brain falls under the tenet regional vulnerability. The idea is that all disorders of the brain start in one area. One particular region is differentially vulnerable. And I think it's common sense to say that if we can pinpoint the area that's most vulnerable, it can begin to give us clues into diagnosis, understanding, and maybe treatment. Yes. I rarely get that complaint, maybe because I started in a somber tone. So the idea is trying to pinpoint the problem with the promise that will open up avenues of understanding and treatment. And I focus on a particular area to illustrate that and to then bring it back to PTSD. Illustrated here, this is an image, an MRI, a side view of the MRI, and I've highlighted in blue an area called the hippocampus, which you've heard about. And down below you can see that there are actually a surprising number of disorders that affect the hippocampus, not only PTSD, but Alzheimer's, aging, schizophrenia. And that immediately raises the question that we're trying to grapple with in the lab, and that is, if I've told you that all disorders have regional vulnerability, obviously these disorders are very different. How could they be targeting the same brain area? And the answer lies in the next slide. not exactly, but almost. This is a cartography or a color map of the hippocampus, one view, showing that there are two of them, but making the point that the hippocampus itself is not just a structure made up of the same kind of neurons. The hippocampus is actually made up of different regions that are interconnected to give rise to a circuit. So think of a circuit of an electric circuit. Each region performs something slightly different, does things differently, connects to different brain areas, and therefore one would hypothesize that insofar that those disorders are different, the list I showed you before, they might target different parts of the hippocampus. And if we can do that, it could open up some insight. And in fact, the previous slide showed you the map, but it actually is a map generated on a very high-resolution variant of functional MRI or functional imaging that could interrogate the broken circuit to ask what part is affected when we compare using these MRI techniques, patients to controls. Next slide. And this is just an illustration of some of the recent application of this high-resolution imaging technique. And wherever you see color associated with each disorder, those are parts of the hippocampus that are most linked to each disorder. So you don't need to know anything about the hippocampal anatomy, complexity. You don't need to know a lot about MRI or functional imaging. I think you can see that the basic principle holds. Yes, they all affect the hippocampus, but they do so by targeting different regions. And with this information, we can now ask, for example, in Alzheimer's, why is that area affected? And we have some answers, and that's led to some new drug development, still very early stage. In aging, it's a different part. We have different ideas, schizophrenia. So the idea is that we would like to now deploy these technologies to understand PTSD within the circuit to try to give us the same kind of level of information to really propel the program forward. Thanks.
Thank you, Scott, and thank you all. Let me, just to pull a little more out of the three of you on this, first of all ask all of you to think about two different images that in this conversation that's about imaging, two bigger images that we've been given. One is of the brain as an organ in the face of overwhelming violence and threat, being injured, being changed in some of its fundamental mechanisms in ways that can be measured, in ways that change how people live. That image of the injured brain, and the brain, too, that can, through treatment in various ways, be measured in its plasticity, measured in its recovery. That's a very important image. But then I would also like you to think about the image of Marty's brother, Teddy, of an individual, like a lot of veterans, who is in whom these changes at a microscopic level in the brain change his life, make him into a person who has scary rages, a person who has overwhelming memories, a person who is socially isolated and needs a tremendous amount of care. So the macro image of that organ being injured, and the micro image and the macro image of the life. And now I would turn to all of you, and maybe I'll put the same question to all three of you, but start maybe with you, Scott, since you're at the most microscopic level, and then gradually work out in our sort of systems analysis. When you hear about a person like Teddy Bloom, any veteran, and you think about the work that you are doing, and in your case with the hippocampus, how does that actually now or down the line translate into practical, effective treatment? What are the implications beyond it's very cool to understand this stuff, which it is?
Right. Well, I mean, I think I'll answer that, but first to say that I think the biggest problem at the time was awareness and the fact that PTSD wasn't familiar, that there were no centers, that there was no psychological support.
Yes.
So
And in fact, it was stigmatized.
It's stigmatized, so even worse. And yes, I'm fairly accused of being a reductionist monkey. That is, I believe in zooming down to levels of cells and molecules to understand disease. But as a clinician who sees patients, it's the ultimate psychological level in this case that matters the most. So that would be, but I will answer the question in imagining if someone would come off a war and have symptoms in the future using these technologies, for example, a patient would not only be destigmatized, but there'd be quick awareness to refer them to hospitals, and the hope is that in the future we would have diagnostic tools that don't exist now. So right now it really depends on psychological interviewing, which is never going to be replaced, but wouldn't it be great if we can pinpoint and say, okay, your problem, yes, you have PTSD, but it localizes to this area. We have a pharmacopoeia of interventions or of therapeutic interventions versus area B. So I can imagine and I can hope that in the future we'll have that diagnostic precision.
And Blair, if someone like Teddy Bloom walks into your office, how is what such a veteran is suffering similar to and different from, and mainly different from, other kinds of anxiety disorders? What are the distinctive hallmarks? Because this is a particularly wounding and particularly gnarly set of life problems.
Sure, and I don't know, do I turn this on somehow? Or just do this, okay. You know, PTSD is a really interesting anxiety disorder, right? Because you get it after trauma. So in some ways, maybe not the only psychiatric disorder, but it is the psychiatric disorder that we, if you will, know the cause, because you can't get it unless you have an external environmental effect. And so I think this aspect of, if anyone wondered whether the environment can change the brain, all you have to do is look at PTSD and realize, of course it can. But then when you look at the effects of treatment in PTSD, and one of the most effective treatments is cognitive behavioral therapy, well, that's the environment again now healing the brain. So your point about the brain being very plastic, but to your question about symptoms. So there are many symptoms people with PTSD can have, and certainly they can have anxiety, like a very heightened startle reaction, which many other anxiety disorders can too. But what you've all said about re-experiencing symptoms, calling back and having nightmares or flashbacks about the trauma event is more unique to PTSD. People with PTSD also can have an incredible sense of numbing, as though they have no future. It's almost a very sort of depressive state, and they can actually have frank depression as well. So it's those features of PTSD that I would call out.
And Yuval, since you and I began talking 15 years ago or something, a lot has changed in the world of trauma science. When a veteran now walks into your new Columbia clinic, how are you looking differently at her or him than someone who would have walked in if that clinic had existed a decade ago?
First of all, I'm not sure whether you were introduced properly. Have you?
I introduced myself. It's all right.
So Bruce is director of the Dart Center at Columbia Journalism. You know, Columbia is a wonderful journalism department, and Bruce took upon a great challenge, which is educating and training journalists who are who present themselves in areas of trauma, photographers, journalists, video. People behind the video cameras, so he has a wonderful program, and Bruce is really a delight to talk with about the issue of traumas, because really the issue of trauma is really about memory. It's about a story, right? When a patient comes to you, he comes to you with a story about an event or about a series of events. And each PTSD patient or each trauma survivor has a unique, very personal and very subjective take about an objective event, right? There have been an event like 9/11, for example, and each of the survivors of those buildings have a very personal and very unique story that should be told in order to help this person. I believe, by the way, that it should be told for historical purposes and perhaps even artistic purposes. But trauma-wise or psychotherapy-wise, somebody needs to hear this person. And what's happening between the therapist or the person who is involved in diagnosis and the person is really digging into this story. Now, that's very perhaps surprising for me to tell you that because, like, Scott and Blair, I'm very interested about the structure and the function of the hippocampus. But that's not the whole truth. The whole truth is that I'm interested in both. And I believe that stories of trauma survivors are the most interesting and most important really to deal with. And strikingly, many trauma survivors are very ashamed about their stories. Many of them feel, a sense of failure, tremendous guilt, and part of the therapeutic process is to take care of those very, very painful memories.
And as you've done this work, to sort of circle back a little bit, what have you rethought? What are you rethinking in your approach to it? Maybe as a result of this kind of research or the insights you've gained from your patients? Right.
In terms of what the science is right now. As I hinted before, I don't think that we are yet there. I don't feel that. And perhaps, Scott and Blair have a more optimistic view about where we are as anxiety or Alzheimer or schizophrenia researchers. I don't think we are yet there. I think we probably have the technology or, we have the manpower, but we lost a lot of time on kind of being, obliged to kind of old type of hypotheses. And I believe that only recently, really, the last, 3-4 years, 5 years, we are starting to see really more innovative and forceful research that perhaps can help us to close the gap.
Let me ask each of you one other thing, and then we can maybe get a few questions from the room. If you were to identify, and again, Scott, we'll start with you, one critical path for research, the gimme, the critical path for making a connection that will make a real difference. In your work, what would it be?
I guess at this point, I believe what I preach. Whereas 10 years ago, I was preaching what I believed. But I do think that having what's sometimes called a biomarker or a biological marker for PTSD would be transformative. We have these debates all the time, are all schizophrenia the same? Is all Alzheimer's the same? Is all PTSD one and the same? That's a fundamental question. It may or may not. And the only way we're going to start sorting through that, I think, is to really have not just imaging biomarkers, you can think of blood markers, or just something that's anchored closer to the brain. I think that, in my mind, once that's established reliably, and that's an important point with all the imaging and all the kind of pretty pictures I showed, it's all about reliability. You can see things on average, but how precise and how reliable is that measure to truly be diagnostic? and precise enough to classify. I would imagine that the day we have that capability in a reliable way to try to start not only sorting patients with PTSD into the right categories, that will, I think, launch a new era in PTSD treatment and research and ultimately treatment.
And Blair, what's your...
I'm afraid I'm going to give you two, which is which is related to what you're saying, Scott, which is what works in whom and why, right? So we know that we can get about half of people well, whether it's PTSD or our other anxiety disorders, and we have very good treatments, and about half of people can even get well in some of our anxiety disorders, and then the other half, we do not know why our treatments don't work, and people still suffer horribly. And in OCD, they suffer so horribly that we do neurosurgery in OCD patients who are suffering that badly. So that's pretty extreme, to have some people you can get well, and some people who are lesioning their brain to have some relief. So the question of what works and who and why, to me, is a critical question. And then the other one I would say is early intervention. I think we wait way too long for people to get treatment. And there's very good data now, emerging data, I should say, in schizophrenia, that with people with first onset schizophrenia, if they stay psychotic too long, it's bad for your brain and it's harder to treat. Like, we probably didn't have to do studies to guess that, right? But the studies are now out there. But I think, what about early intervention for our anxiety disorders? Now, PTSD is an interesting one, and maybe Yuval would say is you wouldn't necessarily go too early, because we all have trauma, and most of us, move through it, and it doesn't last with us. But how do you get someone who isn't 10 years into PTSD? How do you get someone who's 6 months or even 1 month into PTSD, possibly with Scott's early marker or with other markers, and know this person, if you don't treat them early, may actually end up with a lifetime of PTSD. So you want to actually intervene early before the brain gets too used to that set of fears.
Yuval, what's the one thing you wish you knew in this whole messy equation?
No, I think both Blair and Scott really described it. If we are able to predict who will respond well to treatment and when exactly in the process, 2 days after trauma, 6 months after trauma, who are those people really to being able to do a good diagnosis, right? Yeah. And then to assign them to the best treatment. But not only that, by the way, I would be happy if we will be able to also to intervene in the way, the military, the police, and perhaps other professions are really recruit human beings. We know that some people are more vulnerable to psychiatric illness than others, and I think if we can contribute also in screening and kind of assignment, process, this will be good for those patients.
Okay, we have time for a few questions. Shannon has the microphone. Marty Bloom gets privilege of the first one. But Marty, I'm going to say to you what I will say to everybody, which is keep the questions short so that we can get a few in before we have to break and continue talking informally.
Well, you guys got to supply the answer. I'll have the question. The thing you mentioned is interesting. If you know the hippocampus, the small size, is the predisposition, I would call it, to have something like that. What is the earliest you could, like we do maybe now for cancer, that with the gene thing, someone has a predisposition to have that? When could you test for that? And then therefore have that data. So what Blair said, being able to then do something, react more quickly, that you say you see something onset and you know that person's susceptible.
Yes.
Well, I think you answered your question, Marty. It's not the first time that you did that. You usually do that. But seriously now, there was a very famous study on Vietnam veterans where twins, who one of them went to Vietnam and fought in Vietnam, and the other stayed at home. And they found that that twins who develop PTSD in Vietnam usually had smaller hippocampus than those who didn't. But interestingly enough, the twin brother who stayed at home didn't develop PTSD and was healthy, and happy as those who have larger hippocampus, suggesting that perhaps, someday in the future, scientists will be able to develop a set of biomarkers, perhaps blood biomarkers, genetic biomarkers, also imaging biomarkers that can help really dealing with the issue of trauma. We don't want, we have up to 30% of the kids who are going to these wars, coming back with, a range of psychiatric disorders, depression, anxiety, PTSD. If we can, help those, kids to come back healthy and stronger, that's of course better.
I've actually had chats with DARPA. This is the research arm of the military about this, because of course they should care. And it's a really important question, and it relates, as Blair said and you said, to all of medicine early as possible. If there was some kind of biomarker that was feasible and available to all, the idea would be to actually screen all soldiers as they're being recruited. Because back to this issue of precision, any biomarker is only as good as its precision. A lot of them, you think about many screening tests we all do as we age, and how confusing sometimes the results are. They are much more precise when you have baselines. And so actually the NFL is trying to use these kind of screens before players develop traumatic injuries. And so I think that might be the move forward, but it gets back to the issue of, even if they have the will, DARPA is well funded, they have the funding, there's really nothing yet that has emerged as completely compelling. But I think we're on the cusp of that.
So we have time for one or two more. Yes, sir.
Well, I'm a psychiatrist. It's pretty clear from comments of the panel that early intervention for PTSD is not a simple answer. And,
Hold the mic a little closer.
And after 9/11, there were teams that were selling to corporations that had been involved in 9/11 retelling, and I had one or two experiences with patients who were re-traumatized and made worse. And so my question is, I'm sure you all know that, my question is, are there any clues as to knowing which, in terms of evaluation, which patients do better or worse with early intervention, and are there any studies of the people who are more or less vulnerable to being re-traumatized in terms of their neuroscience, their hippocampus, and so on?
The answer is, I think, but is not exactly yet, except this is actually what people are very excited by. They call it precision medicine. We call it precision psychiatry. And the glasses on your face are an example of precision eyeglasses. And imagine, and think about when you get an infection. We don't give you any old antibiotic. We give you an antibiotic for the bug that you have. So imagine if we could, we envision this, right, of a precision psychiatry where you actually can look at an individual and understand why they got their illness and which types of treatment that would be best for them.
Yeah, ma'am.
I work as a psychotherapist, so I'm speaking from that perspective. When soldiers like Teddy Bloom came home after World War II, they had symptoms that I think we characterized as, I had it a moment ago. Shell shock. Now, is shell shock the same or similar to PTSD?
So, briefly, before the terms post-traumatic stress disorder, which is PTSD, which actually was first presented to the public in the early 80s through a manual, a psychiatric manual named the DSM. It was DSM-3 then. Before that, there were a bunch of names, shell shock and combat fatigue, and all sorts of names, railroad, I think, disorders, to describe, a number of symptoms which often occurred with soldiers. Now, after World War II or First World War, there were not, a consensus among doctors and psychiatrists about those symptoms. Later on, through the 80s, there have been more and more effort really to unite the psychiatric community in order to really to diagnose it. Now, what we say to you guys today is that about 35 years later, today, we feel that the description of the clinical, unit or clinical phenomena named PTSD is a little bit too messy. As Scott suggested, and Blair, and perhaps there should be an effort really to be more precise in perhaps a number of PTSD different phenomena. For example, you as a psychologist, perhaps you can, know very well that some patients are more depressed than others, and other patients are more anxious than others, right? So those perhaps may be two different kind of brain profiles that we can refer to and perhaps one day suggest different treatments.
Okay, one more from a non-clinician.
I wasn't finished.
Oh, I'm sorry.
Yeah.
I'm thinking of the other population
Okay.
after World War II, which are the survivors. Patients come to us, second and third generation. They said nothing. Like Teddy, he didn't say anything about his experiences. And the Holocaust survivors said nothing, and their children knew nothing. So now we have a few second generation, a lot of third generation, grandchildren who are going back to where their relatives grew up in Europe and seeing the camps and so forth and wondering. So I can't help but think how significant your clinical work is as scientists to get to parts of the brain that have reaction to trauma and move forward with some kinds of cure.
Thank you.
Sir.
I'm actually Teddy's nephew. This is definitely a non-clinical question. What's going on the patient advocacy side in both making sure they get the benefits and the long-term help they're going to need in terms of where they're going to go? I think Yuval even hinted a lot of the patients don't want to be going to the VA, so they need to get the benefits, and also just a long-term follow-up for patients who don't respond to care. Because in the case of Teddy, he really probably would have ended up in the street had it not been for my mother.
But do you want to talk a little bit about patient advocacy and where that fits in? Certainly in the part where people are thinking about themselves and society and how we all relate to this issue. It's an important question.
Bruce, I think it's a great point for you. Go ahead.
Well, look, I mean, I come at this as a journalist and working with many of my colleagues who are trying to track these issues and who are talking both to clinicians and to veterans. And it does seem to me that there is, First of all, we're blessed right now with a high level of patient advocacy in the current generation of veterans. The Iraq and Afghanistan veterans are working hard to destigmatize PTSD, to raise public awareness. You see groups like Iraq Veterans of America very engaged with this issue. There are parts of the VA, the National Center for PTSD, which has a huge commitment on this issue and is very aware of advocacy before Congress and all this sort of thing. And then you also have big parts of the veteran population that are frustrated by the bureaucracy, by the red tape, that feel isolated. And there, actually, journalists have kind of gone in, leaped into the breach and tried to, by using data and other sources, identify where the problems really are. And there are some scientific problems, but there are really more bureaucratic problems and political problems. And I think that's where sort of we all as non-scientists, hearing all the advances that science has made, come in. Because it's, I think, really only with large public commitment to these issues that both the government bureaucracies and the insurance companies and in particular elected officials can be as fully committed on this as they need to be.
Yeah, I agree completely. I just want to add a personal note here, because I, as Scott, revealed, I had both experiences. I was a soldier myself, and fought and injured, and then I moved to research and clinical work, and the reason I think soldiers face kind of stigma issues and they're afraid to talk, right? Exactly as Holocaust survivors were reluctant to speak. I think there is really a shared problem here. And the problem is that, we, victims or soldiers or veterans, we left the best of us, in the battlefields, right? Holocaust survivors left the best of their families and childhood and communities, in Europe and elsewhere behind, and they moved and they came out of a very traumatic war to a new world in which there was little connection to what they have experienced in combat or during the war. So how to bridge between, a reality of horrors and fears and pain and guilt? How can you really bridge it to a normal society who are coming to clubs in New York City and have cocktail parties? This is really the main problems of veterans, but I would say every trauma survivor, really every or any trauma survivor. So I just want to mention it here for any of you that have been known what I'm talking about, or any of us here, that it's so important really to enable a traumatized person to be able to expect that bridging from the previous reality to the present or future reality is possible, because trauma survivors don't feel that. They don't know that. They don't believe in that. And this is really, and only relationships, as Blair said, only relationships, whether it's loving relationships of family or good care of psychotherapists or psychiatrists, only relationships can enable that. There is nothing else that can enable that, and perhaps this is really a kind of a nice way to think again about Teddy Bloom and about Marty Bloom. Marty is courageous really to bring his brother to the front again, and perhaps offer his brother Teddy many, many years after World War II, this bridge to his life, to the family, to the grandkids, something that they were not able to do that before. So I think that's really the story about advocacy, to be able to tell, that moving more naturally from dark to light is possible.
And that seems like a very good way to end the conversation. Thank you, Scott and Blair and Yuval. The scientists up here have given us and given the world a language for talking about trauma, and that is one enormous change, a language. I would invite you all to use this language over dessert and continue the conversation. And again, thank you, Marty.